I'm here to introduce Wendy Nieuwland, is an occupational therapist who has been actively involved in driver rehabilitation for 29 years. She has been a driving instructor for those with medical issues since 1992 and has achieved her certified driver rehabilitation specialist credentials in 1996 through the Association for Driver Rehab Professionals. She was a contributing author and editor to the seventh edition of the Canadian Medical Association's Determining Medical Fitness to Operate Motor Vehicles, which is one of the main resources on driving for physicians in Canada. She sits on various physician committees regarding how to best assess and screen older drivers and is a specialized advisor to the Medical Review Board of the Ministry of Transportation of Ontario. Her Center Skill Builders is recognized by the Ministry of Transportation to conduct medical driving assessments and was one of the first few driver rehab facilities in Ontario chosen to perform the functional vision waiver assessments for driver of all ages who do not meet the horizontal vision requirements starting in 2005. Wendy has been involved in many other initiatives for the driving assessment in Ontario. We are pleased that she is able to join us today. Welcome, Wendy.
Thank you so much for having me. Hopefully everyone has been finding this talk already very useful and helpful, and I'm happy to help in any way. If I don't address anybody's questions, feel free to put them in the chat. I'll try to answer them as we go, or I can also answer them towards the end as well. So as we all know, this is a complicated skill, very difficult to assess in a physician's office, very difficult to assess in the ER, very difficult to assess when you get to the OT, the speech path, anyone who's seeing the person post-stroke. And we know this because driving is complicated. It's something that's rapidly changing. We have to make sense of everything that we're seeing. The environment is changing all the time. It's not like it's just like how it is when you're sitting in the office. And research, we know, says that you're making approximately 20 decisions for every mile that you drive. And the more that you have experience, which is often the case for our people who've had a stroke, the more automatically these actions are made. So you can all think about the last time you just drove, whether it was earlier this morning or yesterday. You really don't think a whole lot about your driving. You just kind of get there. So this is what happens with some of our automatic thoughts processing abilities, which sometimes can be stolen when we've had a stroke and some of those sort of things. And we know there's so many different things that a stroke can cause that will give us problems for driving. So here, what we know that drivers are required to take responsibility for their change in medical status. That is a requirement. We all signed our name on our driver's license that actually says that, whether you remember doing that or not. And every time when you renew your driver's license, you are acknowledging this. So this is you as a driver is responsible. We also know that physicians and nurse practitioners are supposed to discuss driving with their patients. Every time they have a diagnosis of something related to stroke, that is supposed to be discussed. Physicians and nurse practitioners are now legally required to report a stroke and other mandatory conditions to the MTO as of July 1st of 2018. That's when that mandatory reporting came in. We've always had mandatory reporting of some things, but the scope was really broad, and I'll talk with that a little bit later in the presentation. But we know that health practitioners really should be discussing driving with their patients the same way they would counsel about any other functional skill if they're coming to see them. This would mean that if somebody had a cast on their right leg, then somebody should be talking about them what they're going to do about driving if there's a cast on their right leg. So somebody should have that discussion, and it's no different when it gets more serious, such as stroke. But what we know is sometimes people don't really want to discuss it. Physicians don't know what to say to their patient. They're not too sure what should be happening. Somebody else doesn't really want to have that conversation. It's already difficult enough that they had a stroke, let alone talk about that, oh boy, you probably can't drive either. So sometimes it doesn't get discussed. And I love this next slide. It says 11-foot poles for things you wouldn't touch with a 10-foot pole. because some people really don't want to have this conversation. That's family members, that's the client themselves, the patient, that's sometimes health practitioners, because all the answers are not there in black and white, and the conversation can be really, really difficult. So I'm going to spend some time talking about this requirements for reporting. We heard from our last speaker talking about mandatory reporting and discretionary reporting, and I'm going to just talk a little bit about what that actually is for those people who maybe are not as familiar with it and where it came from. So the Ministry of Transportation is guided by the Highway Traffic Act. Think of that as like the Bible and the be all and end all, whatever you want to call it, regarding driving. So the Highway Traffic Act is Ontario that tells us what we're supposed to do. It's the guiding principle. And we must report anyone who has a medical condition that might affect the person's ability to drive. And optometrists must report visual acuity problems or visual field problems or double vision sort of conditions as well. And there's no difficulties here with privacy of information or needing to get the patient's consent or even telling them that you are doing this report. You can tell them, but it's not required. So I want to give a little bit of background about the program. I was kind of involved in this when this was happening and they were making the decisions. So mandatory reporting here in Canada has been in place for physicians and optometrists since 1968. And we want to call in Ontario that we have one of the most stringent programs in all of North America. And it really was enacted to help protect the public from drivers who are diagnosed with certain medical conditions or impairments that really made it too dangerous for them to drive. And really what was happening is the medical community was saying, okay, driver Jane, you shouldn't be driving, but they were not really able to persuade their clients, their patients, that they shouldn't be driving, and they would be driving anyway. So there was a risk to public safety. And then there was the need to evolve this program and about mandatory reporting because primary healthcare has really changed. You know, there's a bigger scope now of nurse practitioners. There's more involvement with occupational therapists, and even optometrists. Their role has changed in how they're assessing visual fields and acuity and that sort of thing. And previously, the requirements, like I said, were really broad. People didn't really understand about how they should report, when they should report, who they should report, and the medical community as a whole wanted clarity. And so there was also a lot of really a lot of concerns about physician liability. Well, what if I do report? What if I don't report? Am I reporting the right thing? Oh, I'm just not going to report at all. And then there was a lot of issues around the a malpractice and what they were being advised. So this is how it started to come around. We wanted to make sure that we're speaking to the scope of practice for optometrists and occupational therapists, and also make reference to more evidence. So hopefully all of you out there who do a little bit about driving anyway know about the CCMTA standards, and I've included that as part of my handout. So this is the Canadian Council of Motor Transportation, and basically that holds the standards. So our previous speaker was talking about, okay, what do you do when it's a TIA? What do you do when it's a CVA? Well, it's very much laid out in the CCMTA guidelines about what should be done for a person in certain medical situations. So it's not just about stroke, it's about pretty much anything. If you are wanting to know about sleep apnea, what do we do with the guy with sleep apnea? You can go to the guidelines and check what should be done. So that's what they are using for their reference from a reporting perspective. And also, it's to continue to provide legal protection when making reports, because any of us who have to make a report do want to feel that we have some legal protection in doing so, because we don't take this reporting lightly at all. So let's now understand the difference sort of between a mandatory report and a discretionary report. So what the mandatory report is, this is all of the conditions on this form that are mandatory. If your patient has any of these conditions, you must report. That's basically what it says. And on that form, you'll see the word prescribed. That means you, as the healthcare practitioner, you are the prescribed person who's filling out the report. Next, we have discretionary reporting. This means the people who are the prescribed people, who are the healthcare practitioners, may report a person who maybe has or appears to have a condition that might make it dangerous for that person to drive. So perhaps it's something that's not necessarily listed on this form, the mandatory reporting, but there is concerns. Or if, let's say, an OT, that was talked about in the previous presentation, if the OT, because we're not allowed to diagnose as occupational therapists, but we want to make a discretionary report because we have concerns about the person's fitness, then would be appropriate for a discretionary report. So if we look at who does mandatory versus who does discretionary reports, physicians, optometrists, and nurse practitioners all have mandatory reporting. They must report it. But they also can have discretionary reporting, but who's added in here to this list is occupational therapists because of our knowledge of functional based and about driving and fitness to drive. So when we're using the forms, this reporting form, it's used by all of these people, the categories of people. There is a specific form that's for vision as well that's used by optometrists, but they can also use this same form. And if anybody wants to find this form, you can find it. Just a quick Google search will get you to it, but it's really kept on the Central Forms repository. And for anyone who's not seen a form, I'm just pulled this up here. So this tells you about how to complete the form, what you're supposed to do. And this is the first page of the form. So it's 2 pages. And you really are to put down as much information as you can. If you don't have all the information, that's okay. If you don't have their driver's license number, that's okay. Fill out as much as you can. Typically, their first and last name and their date of birth. Even if you just know that they live in Sudbury or they live in Valcarin or wherever they live, you can put that down and usually they can figure out who this person, who would be appropriate for this person. And if you look down to the towards the bottom here where it says number 1, cognitive impairment. So cognitive impairment, that's one of the reportable conditions. A sudden incapacitation, even if you don't know why that is, that would be a reportable condition. And then when we get to page number 2 is where we start to see all about our CVA stuff. So we're talking about a sudden incapacitation that was from a CVA or cognitive impairment. So you can see there under number 2, number 3, number 4 are all things that have to do with stroke. So the person can have multiple issues. So you might be checking multiple different boxes or not. You can just check one. That will be enough to get the information to the Ministry of Transportation. If you're going to report a discretionary, you go down to box 7. You don't complete anything else in box 1 through 6. You just do box 7 and talk about why you are making this report. So let's talk about how this is then going to be sent. So you're going to send this form, complete it, sign it, send it. You can mail it, you can fax it, you can email it. And I've put it there on my form. If you want to take a screenshot, feel free. This information is also available on the Ontario website as well. But what's going to happen when you send in this report? That's what everybody wants to know. So really, you are not the one taking anybody's driver's license away. You are not the one saying that they can have a license or not have a license. Only the Ministry of Transportation can say that. So, but it is our job as healthcare practitioners to give information that the ministry can make use of so that they can determine who's a significant risk and if there's any immediate action that needs to be taken. So just because you report them doesn't mean it will always result in a suspension. It may just trigger the fact that another form gets sent to them. In this case, we're talking about stroke, so it would be a cerebral vascular form that would get sent. But if they also have a comorbidity and they're also diabetic, let's say, the patient might get sent 2 forms, the cerebral vascular form and a diabetic form, and they would have to take that to their doctor, and then that's where they get more information about what should happen with this person. So really, if I put in the bottom of this slide here, usually it results in more medical information. Sometimes it says, oh, we need you to go for a functional assessment, to have an individualized functional assessment to see if you, patient with a stroke, is okay to be driving, yes or no. Or maybe they want to be sent for some other kind of testing. But whatever the MTO is requesting, that is what is required. So I won't get too much into this because I think all of you know this, who's on this call, that everyone is so very different who's had a stroke, from the aphasia that we talked about earlier, to vision problems, to cognitive problems, physical. Sometimes people are just more emotional after they've had a stroke, and that makes them super nervous. And then when they're trying to drive, they're not doing very well because they're super nervous. And then, of course, all their comorbidities that were there or maybe led to part of the stroke or whatever is happening also contribute to their skills and abilities with respect to driving. So how can the doctor or the health practitioner assist the patient like right away? I love those resources, like I said, from the last person's presentation that were excellent. But really, what we need to make sure that the doctor or the health practitioner is saying is that, okay, patient, you have to have had enough medical recovery, like that you're okay to go back to driving. We got to figure that out first. And you have to be medically stable because we want to make sure you're not going to have another stroke when you go back to driving. So those are sort of things like very basic things that we need to communicate to the patient. And we need to make sure that we tell them that we not need to make sure that they're ready to return to driving. And oftentimes I'll say this to patients or people that I'm talking to, we have to treat driving like no different than if they had a heart problem. Okay, guy here with the heart problem, we're going to send you to the cardiologist. We need to run a battery of tests and figure out what medication is good for you. And we're sending you off to the specialist to get that all figured out. Family doc is awesome at doing the screening and getting it going and handling what they can. But when the specialist is required, they of course make that referral. So sometimes that's what has to happen with driving as well. So sometimes the physician, the other health practitioner, an OT, a speech therapist, they might be doing some bits of driver screening and counseling and doing rehab planning and doing all that sort of stuff. But sometimes they are going to need to have an assessment specifically about function and if they can drive. And then we talk about whether a report is needed. So they may or not need an assessment, like we said, but since the stroke is a mandatory condition on the report, usually that's what happens. But like I said, the MTO will be the one to decide. So the physician and the health practitioners are giving their information, and it's up to the MTO to decide. And if your report has said whatever you've said about the patient, that is what's going to be used. And I ask that you be as specific as possible. If you really think this person should not be driving, write that on your form. They will listen to what you have to say. If you think that, oh, they just need to wait for 4 weeks and then they should be okay, write that on the form. Whatever you want to happen, write it on the form because that's usually what has happened. But if they have been reported, if you've done a report, or maybe let's say the health practitioner has specifically asked for a fitness to drive assessment. Let's say they sent them straight to the functional assessment center rather than reporting. There is less liability for physicians and health practitioners if this has been specifically addressed in one of those two ways. But I suggest that you all check with your malpractice insurance provider and ask them if they agree with that. This is some information that I have gotten from them. I also urge you all to look at that CCMTA guidelines. And I just took a snippet here from one of the pages of the book. And it talks about here what should be done, what's being done across Canada for people who've had this. So for example, if somebody has had a TIA, the waiting period is 1 month. The patient may return to driving if there's no residual deficits that are affecting motor, vision, or cognition. That is the guideline currently. If they've had a moderate stroke with mild deficits, the waiting period is often 3 to 6 months, again, depends on progress in their recovery, and a formal driving assessment may be required, one that includes the clinical assessment as well as on-road testing, which is exactly what we do here in Ontario. And then it goes on about severe strokes, or if somebody has AFib that's not quite under control, there's a very specific information in these CCMTA guidelines that definitely helps physicians and nurse pracs to really figure out what they should be doing with their person in front of them. For patients, this is what I like to tell them, is do everything you can to help with your recovery, because that's really important. Engage in therapies that help you compensate or recover from the deficits that could affect your driving. Also in the MTA guideline, they have really specific skills and deficits and how they can affect driving. And sometimes I've found that very helpful to share with clients. And make sure that the clients themselves are getting active in their regular self-care and active in their home skills prior to the next step, which might be returning to driving. Because if they're sitting at home, not doing a whole lot otherwise, and they think that driving is their next step, sometimes healthcare practitioners can be the ones that help them through the rehab journey by getting them to be more active, which is an excellent preparation for driving. So I say become re-involved in your home life. OTs will know about the Mission model, but I like to pull that up often, talking about how driving is a 3rd or 4th level skill, and what they can be doing to help with that. So next, people want to know, are you ready to see if you can drive? If you've done all that, you've done your rehabilitation, you're working on it, you think that you're feeling ready, then what? So then what you can do is be assessed at a functional assessment center, and the MTO can require this. They could actually request it and require it. The patient or the family can initiate this themselves. A physician or anyone on the medical team really can make a referral for the assessment, but we don't really need a referral to do the assessment. So like I said, FAC is what you're going to hear. It will say that on the form, even on the cerebral vascular form that physicians fill out, it says, does this patient need a functional assessment? I find that a little bit misleading because it's hard to know what that actually means, but what it does mean is one of these type of assessments where it's an occupational therapist who specializes in driver assessment and rehabilitation, along with a licensed driving instructor who has also been trained by the Functional Assessment Center to collaborate in these assessments. And it takes about 2.5 hours to do this assessment, and we are actually observing them driving. The costs range, somebody was asking in the chat about the costs and that sort of thing. Across Ontario, from my last looking at this, is there anywhere between $700 and $900. And just to speak a bit more about the costs, it's not covered by OHIP. All of us who do driving are very disheartened that it's actually not covered by OHIP because it's a skill of everyday living. It's a self-care skill in this day and age. Maybe it wasn't, 30 years ago, but it sure is nowadays. Especially when we're talking about Northeastern Ontario and where we live, there's not transportation or other options for people. And it really is a skill and necessity of life for some people to be able to drive, and it's unfortunately not covered. For example, if you had your stroke and lived in Quebec, it is covered. So, I don't know what can be done. If anybody out there on this call has any any tips or tricks of how to advocate to OHIP about that, that would be fantastic. Okay, so Functional Assessment Center, what is our goal? Well, our goal in assessing the patient is safety first, for sure. And of course, the client's goal is also they do wish to be safe and they would like to drive. So they understand that safety is absolutely the goal, and that our goals is really to answer sort of this question: is your stroke affecting your ability to drive? Yes or no? If no, well, then you probably can go back to driving, and our evidence that we get from our assessment will tell us that. However, if they can't, is there anything we can do about it to help? And they would like to know that too. Does that mean giving them driver rehab sessions will be helpful? Do they need to go back to work with their outpatient OT? Do they need some adaptive driving equipment because maybe one of their arms doesn't work or their right leg doesn't work? Maybe they need those things, but this is really the goals of what we are trying to address through this assessment. So this is not like an assessment for a 16-year-old who's going for their session, I don't really care if the client didn't exactly stop behind the white line exactly where they're supposed to if they were 16 years old. What I do care, though, is can they make the judgment of what they're supposed to do? They have a lot of years of driving under their belt, typically, people who come to see us post-stroke, and I need to know, is it their stroke causing them any problems with their driving? So this specialized assessment, like I said, it's really is determining that medical conditions impact on their skills and abilities for driving. And it really is the gold standard for determining medical fitness to drive is an on-road assessment that is completed by someone who knows about both medical conditions, functional skills and abilities, and driving. So it's also determination, like I said, about if they will benefit from training and if any adaptive equipment is appropriate. Not everyone who's assessed is appropriate for training, and it's based on those skills that we see and what their deficits are, whether we think they will benefit from this. So like I said, the assessment usually is about an hour and a half to 2 hours. We're looking here at their medical conditions, multiple medical conditions, reviewing all the medications that they take, what's going on with their license. Do they have a license? Is it suspended? Might be suspended if they don't complete this assessment? What's their driving history look like? We need to know about their vision because if people have a vision deficit where they are missing peripheral field, then they have to undergo a different style of assessment called a vision waiver because they don't meet the requirements that the Ministry of Transportation has set forth. So we have to do a different type of assessment. So we have to figure that out as well. We look at how their emotional status is from the impacts of the stroke and maybe again past medical problems as well. Looking at the cognitive and perceptual functioning of them post this stroke and how are they physically? How's their arms and legs functioning? Are they going to possibly need any adaptive equipment? And they also need to know how this will affect them and their vehicle and their family member in the future if they need adaptive driving equipment. So we talk all about that as well. And then we take them out on the road and it's about 45 minutes-ish, depending on traffic, depending on what they can do. And we are really looking at their driving performance. How are they doing? How are they able to respond to feedback if we're giving them some feedback about things? And this whole assessment is really tailored to this patient specifically. Then after that, we tell them right away that day about how they did. Are they yes, they're good to go? Are they a no-go and we think they need more medical recovery? Or are they somewhere in between and they need some in-vehicle training? Or should they go back to their healthcare provider to get, some vision training or some kind of cognitive rehab, that sort of thing? And if they do need adaptive driving equipment, let's just say the person has a right-sided stroke is affected, so maybe they can't use their right foot reliably enough, and we need to recommend a left foot gas pedal versus if they maybe need something to steer the vehicle because one of their arms doesn't work, or they can't reach the signals because their left arm doesn't work very well. We might use something called a turn signal adapter. Here's a spinner knob. If we looked at this as a clock, I would call this at about the 2 o'clock position. That would compensate for somebody whose right arm isn't able to participate in the steering. If let's say they can't also turn on the signals, the wipers, the washers, we might introduce them to something like this where they hold onto the knob, but they can push these buttons that activate the horn or activate the wipers or the signals, whichever. And we have these things in our car so that we can try them out during the evaluation and then carry on with training as needed. This is what a left foot gas pedal looks like. So the picture on the right is a manual style, which means it's attached there at the floor. And you can see how there's a newly located left foot pedal that the person's whose right foot doesn't work would use their left foot to depress a newly located gas pedal and keep using the regular old brake pedal. And the one on the left, this is my foot in here I have, and I'm onto an electronic left foot gas pedal, which is just a little bit less cumbersome and much, I would say 95% of people get this one these days because it's just so much easier. You push a button, it's activated, you don't push the button, and your driver who's, your spouse or family member who wants to drive the car just drives the car regularly. There is a lot of resources that are out there and available. Like I talked about, the Ministry of Transportation has some information on their website. The College of Occupational Therapists has an excellent guide to discretionary reporting for OTs. And then again, I keep referring to this one, the Canadian Council of Motor Transport Administration, the CTMTA. Like I said, you're getting that as part of your handout. It's many, many, many pages. I want to say 300 pages. Don't print it. I keep it as a PDF on your computer so you can refer to it when you need to. Here's I took a page out of page 21 out of the CTMTA that I was telling you about, where we want to say, well, what's the function that's needed for, let's say, cognitive function for driving? Divided attention. What does that mean? Well, it's the ability to attend to two or more stimuli at the same time. How is that relevant to driving? And then it talks about responding to the roadway ahead while being able to identify stimuli in the periphery. So that's talking about divided attention. That's not yet talking about your peripheral fields, your actual visual skills. So you can go into the CCMTA and look for these things, and it's really quite excellent. Okay, so I know there will be lots of questions, and I'm wondering if we're able to, unmute. People can just ask the question rather than just being in the chat, or we want to open up the chat. What do you think, Sue?
Hi, Wendy. That is excellent. Thank you very much. We have a question in the chat. Can you comment on filling in part 2 of the form when making a discretionary report? The 3 questions about patient aware of report, consent to release to legal representative, ... I'm unsure how to respond to the bottom 2 questions.
Okay. So sorry, what was the number? Is it part 7?
Yes, in the discretionary.
In discretion, put whatever
There's
you
3
like.
questions. She thought there was 3 questions.
So you can put whatever you like there. There is no requirement of what you must put, but what you should do is you should describe. It can be one sentence. What is it that makes you concerned about the person, or why you think that it needs to be investigated? Put that down.
Said there are 3 questions about patient aware of report.
So you can write down, so if you're telling your patient that you are reporting them and why, you can put a check mark. There's also another question on there that says that if you don't want to tell the patient and you want to just go ahead and report, but if they inquire about who reported me, and you want to be told that, you can check that off. And that's really about your own safety. If you think that there's a safety concern that I'm coming to get whoever reported me, whatever is the situation, the MTO will notify you if the patient requests that, if you check that off.
Okay, thank you. The next question is, are there any guidelines for driving with an AFO?
No. So there is no guidelines about that. So can a person drive with an AFO? Maybe. That's the same sort of question I'd say if somebody could drive with a prosthetic leg. Maybe. It sort of depends on their function. Again, comorbidities, what's going on, how much movement do they have through their hip and legs. Some people will think, oh, I'm amazing with my AFO. I can do it with my AFO. But then you get them in the car and it's like them driving with you and I putting on a ski boot on our leg. You can't feel the pedal, you overshoot the thing, your proprioception isn't as good as you thought. So there's a little bit more that goes into it. But again, that's why everyone is given an individualized assessment so we can determine that. If a patient wants to maybe be able to do that, that's good. A discussion I always have with people when we're talking about an AFO on the right leg, that's usually means because they don't want to have a left foot gas pedal if they could drive with their right leg. And I agree. If we don't need to prescribe any equipment, let's not. We rather not give them adaptive equipment. But if they need it, it's because we think there's a safety concern. And sometimes our patients will say, but I want to use my leg. They tell me to use my leg all the time in driving, or put my hand up on the steering wheel because, the more therapy, the better. I agree with the statements that they're saying that they want to have more therapy and make sure that it's being useful. But unfortunately, driving is not the place for that to be your therapy time, about learning that that's when you're going to make your leg move better. That's the time when you're going to make your hand move better. Those are not the time to compromise on the control of the vehicle. So we have those conversations with the clients. It's not so easy sometimes because they would really like to. But again, it's a functional assessment and it's the evidence that guides whether we determine they can or can't drive with the AFO.
Right. Okay, next question. As you know, Sudbury area lost our DARS program. Is the in-clinic portion completed in Sudbury when a patient's referred to skill builders?
Yes. Yeah, there's a functional assessment center in Sudbury that's run by skill builders. The
Okay.
hospital unfortunately lost their program. That's really unfortunate. That's been just over a year now that they lost it. It was October 2023.
Right. Okay. A response from the person asking about filling out the discretionary part. They said that they were asking about part 2.
Oh, part 2. Sorry. Part 2. Oh, the practitioner's information. Sorry. Okay. So I provide, so I'm assuming it's the yes, no boxes. So I have provided my patient or their lead with a copy of this report. You don't have to. You can just say no if you didn't. You don't have to provide it though. I approve of the ministry releasing this report to the patient if requested. You can say yes or no because you don't have to if you don't want to. If you wrote something on there that you just feel like, if you said this person should absolutely not be driving, like obviously we want to write respectful things, but if maybe you've documented it in a way that might be derogatory or something not so good, you might want to put that. But I wish to be notified if my patient requests a copy, and that's what I was saying. It's because of for your own personal safety. You can answer those however you want.
Okay, perfect. We only have a few minutes left. There's a few more questions. Can you discuss the cost associated with the driving test? I've sent a few patients who said it was fairly expensive. Is this standardized?
Yep, so I said that already in the presentation. It's between $700 and $900. That's across the province.
Okay.
That's because it's, like I said, 2.5 to 3 hours of the occupational therapist time. Then you have to pay for the driving instructor, pay for the car, pay for all the equipment, pay for all the insurance, as you can imagine, with somebody getting into the car that might not be fit to drive. So we pay an extra boatload of insurance for that reason. And then we have to get them a temporary permit from the ministry. There's just a lot to be done before they get when we're there. Then we write a report all about how it goes. Then we have to write another report, an MTO report. So the total OT time is really a lot, which is where the $700 to $900 comes from.
Right, thank you. And someone just wanted to clarify, so we do not need client consent to complete a discretionary report.
Correct. You do not, not for a mandatory report either. You do not need their consent.
And
In fact, you're protecting yourself by reporting, because if you decide not to report and the person goes out and drives and crashes and they're under your care or we're under your care, that could come into question.
Right. So Jeanette, our speaker from just before you, also put a link if people are interested to a resource for discretionary reporting. And another question, does Skill Builders provide compensation to medical professionals for referrals?
And no.
No.
That would be illegal and against the law.
Right. Thank you very much for coming today. We appreciate it.
My pleasure.